In this video, we will discuss Torsade De Pontis, its etiology, pathology, clinical features, causes, EKG features, and a diagnostic approach to the treatment. So what's Torsade De Pontis? Torsade De Pontis, or in simple English, Torsade De Pontis, is a French word which means twisting at a point. Twisting occurs above and below the isoelectric baseline. Ventricles depolarize in a circular fashion, resulting in QRS complexes with a continuously turning heart axis around the isoelectric point of the baseline. The VTEC of the Torsade De Pontis is characterized by QRS complexes of changing amplitude that twist around the isoelectric baseline. There is a long QT interval. The rate is 200 to 250 beats a minute, and VTEC when the rate is more than 100 beats a minute. So what type of VTEC is Torsade De Pontis? There are two types of VTECs, monomorphic and polymorphic. So what's the difference between a monomorphic and a polymorphic VTEC? In monomorphic VTEC, QRS complexes are uniform in shape, whereas in polymorphic VTEC, QRS complexes vary from beat to beat, as occurs in the Torsade De Pontis. So Torsade De Pontis is a polymorphic type of ventricular tachycardia. Polymorphic VTEC may be produced by acute ischemia, myocarditis, or changes in the QT interval or electrolyte imbalance. The most common arrhythmia mechanism is re-entry that occurs due to block or fibrosis. So the normal QT interval is 450 milliseconds, and a QT interval of more than 500 milliseconds is a long QT interval. Risk of Torsade De Pontis increases by more than 1.5 folds if QT interval is more than 500 milliseconds, and if QT interval is more than 550 milliseconds, the risk of TDP increases by more than 2 folds, and this occurs due to after depolarization defect that occur due to increased intracellular calcium. The two types of after depolarization are early after depolarization that occurs in phase 3 of the action potential. Early after depolarization that occurs in phase 3 causes premature ventricular contractions that triggers polymorphic VTEC or TDP, causing fainting, seizure, polymorphic VTEC, white complex tachycardia, ventricular fibrillation, and sudden death. Torsade De Pontis may terminate spontaneously but may recur and may be converted to ventricular fibrillation. Most patients with VTEC have a structural heart disease and show a prior Q-wave myocardial infarction during sinus rhythm. So the causes of Torsade De Pontis may be congenital or acquired. Congenital causes are due to the disorder that have long QT interval. Acquired causes may be cardiac, non-cardiac, or drug-induced. Cardiac causes are bradycardia, CCF, LVH, myocardial infarction, and myocarditis. The non-cardiac causes of torsade include fluid loss, electrolyte imbalance, malnutrition. Fluid loss may be due to diarrhea and vomiting, and electrolyte imbalance that cause Torsade De Pontis are hypokalemia, hypomagnesemia, and hypocalcemia. Malnutrition conditions that cause TDP are alcoholism and anorexia nervosa. And what drugs cause TDP? ABCD, antiarrhythmics, flecainamide, procainamide, quinidine, and sotalol. Antibiotics, erythromycin. Antipsychotics, phenothiazines. Antidepressant, tricyclic antidepressants, and digoxin causes TDP. Other causes include hypothermia and hypothyroidism. So the endocrine disorder that causes TDP is hypothyroidism, and subarachnoid hemorrhage may also cause TDP. So amongst the antibiotics, erythromycin, and amongst the endocrine disorders, hypothyroidism, they may cause TDP. So what are the EKG features of TDP? Which EKG feature causes increased susceptibility to Torsade De Pontis? A very prominent U wave. A normal is less than 1 millimeter. A very prominent U wave is a feature of increased susceptibility to Torsade De Pontis. A 12-lead EKG tracing helps to establish a correct diagnosis of white complex tachycardia. tachycardia. 12-lead EKG that suggests VTEC with slurring of the initial portion of the QRS, a QRS duration of more than 140 milliseconds, bizarre QRS, and a large S wave in V6. Rate is 250 beats a minute. P wave in TDP is absent or buried in QRS complexes, and QT interval is long. And most patients with VTEC have a structural heart disease and show a prior Q wave myocardial infarction during the sinus rhythm. Diagnostic approach for TDP. In patients with polymorphic VTEC, a characteristic twisting of the QRS complex occur around the isoelectric baseline. In these patients, EKG is done in sinus rhythm. If QT interval is prolonged, then it is Torsade De Pontis. Otherwise, it may be due to other conditions like acute myocardial infarction or cardiomyopathy. Treatment of torsade. Infusion of magnesium sulfate and antiarrhythmic drugs. Which antiarrhythmic drug? Lidocaine or phenytoin may be used to treat Torsade De Pontis. Why? Because they do not increase QT interval. Number 3, correction of electrolyte imbalance, withdrawal of the offending agent, avoid medication that can increase the QT interval. Temporary pacemaker can also be done. What about the cardioversion? Because of the polymorphic nature of the torsade, synchronized cardioversion may not be possible, and the patient may require an unsynchronized shock or defibrillation. Sustained polymorphic VTEC causes collapse, therefore they require immediate asynchronous defibrillation. If arrhythmia persists, repeated shocks with maximum energy output of the defibrillator are essential. IV lidocaine can also be given. A VTEC of more than 30 seconds is sustained VTEC and is treated with an implantable defibrillator. Implantable cardioverter defibrillator brings back the patient's baseline cardiac rhythm. VTEC in patients with structural heart diseases is treated with implantable cardioverter device. Why? Because ICD device provides rapid pacing and shock therapy in most VTECs effectively. But more than 50% of patients with VTEC and ICD need adjunctive antiarrhythmic drug therapy to prevent VTEC recurrences.